Project Proposal by Hunter Miller. Right here is my certificate of original authorship, just saying that this is all my own work and I did not plagiarize or copy any other work. So the issue that I identified and I chosen for my clinical problem is inaccurate or incomplete medication reconciliation at admission and during transitions of care. Reconciliation errors that lead to adverse drug events, patient dissatisfaction, and compromised outcomes. Some things that I would like to work on are improvement of safe medication administration, reducing readmissions, and enhancing patient safety. Efficiency, effectiveness, and financial savings. So for improving medication reconciliation, some things we have to do for increasing our efficiency is less duplicative charting. We also want to prevent errors by reducing extended hospital stays. We want to enhance effectiveness with accurate treatment decisions, and our financial impact saves about $2,000 to $9,000 per adverse drug event. Ethical policy and legal concerns. So for our ethical, we want to demonstrate non-maleficence or avoiding patient harm. Legally, hospitals are accountable for Joint Commission standards that we must all follow. Our policy must align with national patient safety goals, and our focus is mainly on medication reconciliation at transitions of care. Stakeholder analysis. Everybody has a part as a stakeholder in the hospital setting. For instance, our high power, high influence, our nurse managers, pharmacists, and hospital administrators. Our moderate power, moderate influence, our bedside nurses and IT staff, as they control the electronic health record optimization. And our low power but high impact are our patients, families, families, nursing assistants, and just many, many more. Basically, like our customers for our business. Root cause analysis. So, why do errors occur? Why are these errors occurring? Well, it's because information is being missed during admission. And, you ask yourself, why is information missing? Well, patients often cannot recall all medications, and sometimes it's also due to staffing error. But majority of the time, it is the patients that cannot recall all their medications. Why is there no backup? There's just no standardized process for verification. It's kind of just a trust game and just, based off of the client's knowledge. Why is verification inconsistent? Staff are rushed and procedures vary. Many hospital staff are always rushing to do many different things. And you ask yourself, why is their time limited? Well, staffing levels and workflow inefficiencies. You're not going to have the perfect workplace. That's just not possible. That's not feasible. It's ideal, but it's just not feasible. Collaborative team members. So some collaborative team members I'm working with are BSN nurse Emily Johnson, RN/BSN, oncology nurse with 8 years of experience, and other healthcare professional Michael Green, pharmacy department clinical pharmacist specializing in chemotherapy and drug interactions. The change agent role. As the change agent, I would and should recognize the need for change, safety issue, diagnose the problem, process gaps, assess motivation capacity for change, nurses and pharmacists, select the change objective, improve reconciliation accuracy, choose the appropriate role, facilitator and advocate, maintain the change, ongoing monitoring and feedback, and terminate the helping relationship, sustain practice independently. Brainstorming with collaborative team. Emily standardized reconciliation forms are her suggestion, and Michael suggests pharmacist-led double checks. Combining these, we have a standardized electronic checklist in our electronic health record. We're hoping that this can definitely help out with medication reconciliation and less problems with patient care. For evidence-based literature, Mueller found that pharmacists' involvement in reconciliation reduces errors by 70% according to his study. Manius show that standardized electronic forms reduce omissions and duplication, according to his research. Um, so, for our improvement goal and SMART objective, our primary goal is the improvement accuracy of admission, med reconciliation. For this is from Emily's side with oncology. SMART objective, we want the timeline to be within 6 months. We hope to have this happening and performing well within 6 months. And our target is reducing errors by 30%. Strategy for this would be just the standardized electronic checklist and a pharmacist review. Force field analysis. Some driving forces are patient safety, accreditation requirements, and pharmacist support. Meanwhile, our restraining forces are nurse workloads, staff resistance to the electronic health record changes, and some strategies that we can implement to help us out with this is education sessions, workflow integration, and staff incentives. Change model application, or Lewin's theory. So for this, our unfreeze would be to share data on reconciliation errors and risks. Our change would be to train nurses and pharmacists to use the electronic checklist. And our refreeze would to be embed checklist in electronic health record and audit compliance monthly. Implementation strategies, we would use education workshops for the RNs, interdisciplinary meetings with the pharmacists, posters and reminders on units for any other staff members, and recognition awards for units with the highest compliance. Basically just rewarding good behavior. Influencing adoption, so our innovators would be to engage early with pharmacists and tech-savvy nurses, as they would probably have the highest interest out of anybody. Early adapters, nurse leaders and charge nurses, as they are the leaders, people will follow. Early majority, general RN staff, this just has to be standard. Late majority, more resistant staff, they're probably going to be the hardest to get down with the new implementation, and laggards are continuous mentoring and one-on-one support. Monitoring progress. Success will be measured by input, staff training completion rates. Our process is the percentage of reconciliations using a checklist. Output, error reduction by 30%, or our goal, our target. And quality, we want fewer medication-related incidents and improved patient satisfaction. And for our reflection portion, we really just want the balancing safety workload and financial factors to be known as complex. And with this, we just want to focus a lot on teamwork, like interdisciplinary teamwork. We want to share responsibility and safety. We want our structured change strategies to address systemic problems. And we want our outcome to mainly just improve patient outcomes despite challenges. Our patients always come first. Patient is priority more than anything. And here are my references. And I just want to take the time to thank you for listening. Thank you for taking the time to listen to this voiceover. And yeah, thank you so much and have a blessed day.